Yes, I'm Joan Guitart. I'm the director of the Cutaneous Lymphoma team and the Laboratory of Dermatopathology at Northwestern University in Chicago. I've been at Northwestern for over 30 years, taking care of patients with cutaneous lymphomas. And I've had always an interest in clinical pathological diagnostic issues related to CTCL. And I've always done my best trying to help patients get a prompt diagnosis and a treatment approach that works with them. And overall, I'm proud to see how we are doing a better job at diagnosing our patients early, and we are doing a much better job now than a few years ago in terms of achieving good results with our patients. Well, Mycosis Fungoides and Sézary syndrome are two sides of a coin. We are talking about the same disease, malignancy of mature and primed T cells, primarily T helper cells, that home in the skin. That's why they are cutaneous lymphomas. The initial presentation tends to be, not always, but tends to be in the skin. But due to some molecular differences between Mycosis Fungoides and Sézary syndrome, one of them, MF or Mycosis Fungoides, is mostly localized to the skin, versus Sézary syndrome or the leukemic variant, which, although it presents with redness of the skin, what we call erythroderma, there is also a blood component from the inception. So that's the main difference. Sézary syndrome defined as the leukemic variant of cutaneous T-cell lymphoma versus Mycosis Fungoides, the primary cutaneous presentation. So even though we have two distinct entities, there is some overlap. So we have patients who early on are diagnosed with Mycosis Fungoides. They may have just a few patches of redness in the skin. We do a biopsy. The biopsy is consistent with Mycosis Fungoides. The patients may have a simple blood count, a CBC with a negative results, or not even have a CBC. And the patients carry a diagnosis of Mycosis Fungoides. And over time, the patients may become red from head to toe or erythrodermic. And over time, the patients may develop blood involvement and adenopathy. So this distinction between those two entities and those areas of overlap are important to keep in mind. Cutaneous T-cell lymphomas, unlike other lymphomas, are detected early on. Why? Because the patients present with a rash that they don't know if it's an eczema, they don't know if it's psoriasis. The disease burden is minimal, and the patients are perplexed. They go to the dermatologist and they obtain a skin biopsy. Initially, they may try topical cortisone creams, and the lesions do not go away. And pretty early in the evolution of lymphomagenesis, we obtain a biopsy. So again, that's very different than other lymphomas of nodal or other systemic areas where the diagnosis is often reached when the patient has a high tumor burden with big masses that are palpable, or the patient presents with constitutional symptoms, and often at the stage of diagnosis is an advanced stage. So in Mycosis Fungoides, we are able to witness the early stages of lymphomagenesis. And when we review those biopsies, often they are non-diagnostic. By that, I mean that the tissue may show a few tumor cells versus a lot of what we call tumor-infiltrating lymphocytes. T-cell mediated immune response against the malignant T-cells. And the reactive T-cells and the malignant T-cells can pretty much look alike. So often, those early stages of Mycosis fungoides are I wouldn't say misinterpreted, but more like underinterpreted as eczema or as dermatitis unspecified. So that's probably the main issue, and the patients may carry the wrong diagnosis, or they are underdiagnosed for several years. So actually, there was a study years ago that showed that in order to reach a diagnosis of Mycosis fungoides, it may take an average of 6 to 7 years. So this delay in diagnosis, yet an early signal that's undervalued, is a common issue. So a second aspect that makes the diagnosis challenging for the clinician and for the pathologist is that we are dealing with a malignancy of mature and prime T cells. That means that those cells are immunologically active. That means that those cells express molecules and have a microscopic appearance of a benign or mature cell, pretty much similar to chronic lymphocytic leukemia for B cells. CLL, the cells are small and round like normal lymphocytes. So this is not a blastic condition. It's not, early on, it's not like large cells. So it's not something that calls the attention of the pathologist under the microscope. So those mature T cells are immunologically active. They interact with the microenvironment of the skin, and they may resemble microscopically and clinically other conditions like psoriasis, like eczema. Some cases look like vitiligo, there is hypopigmentation. Some cases may look like hyperpigmented, like lichen planus, for instance. So there is a wide variation of clinical presentations. So a myriad of clinical and pathological presentations, which would pose a diagnostic dilemma for both the clinician and the pathologist. And this can go on for several years, as I said earlier. I think it's important to keep in mind for clinicians in general, whether we are talking about general practitioners, dermatologists, hematologists, that a patient with red skin, what we call erythroderma, it can be the first sign of leukemia, which has a very poor prognosis. And even though there are many different causes of erythroderma, from psoriasis, atopic dermatitis, pityriasis rubra pilaris, even a bacterial infection can cause erythroderma. Patients with erythroderma, you must rule out Sézary syndrome. So all patients with erythroderma should be checked with a CBC, looking for lymphocytosis. And even if they don't have lymphocytosis, I would recommend flow cytometry analysis, which may show early signs of an abnormal T-cell population that must be followed, and these patients will need further workup. So including flow cytometry in the workup of patients with red skin of unknown cause, what we call idiopathic, is essential. Staging is important because it provides some guidance to the clinician about therapy and provides prognostic data for the patient to know what to expect. So proper staging is important for us to plan the road ahead. And what happens is that if one of the, so in general, the way we stage patients, we use the TNMB staging criteria. So T is for skin burden of disease, B for blood burden of disease, N for nodal burden of disease, and M presence or absence of mesenchymal organ or internal organ involvement. So those 4 stages, knowing whether they are involved with the disease or not, are important for prognostic and therapeutic reasons. So a proper diagnosis early on will require evaluation of all those areas. That doesn't mean that we have to do a major workup with PET CT scans and bone marrow biopsies. I'm not saying that, but at least we need to look for signals of potential internal involvement by blood analysis, palpation of lymph nodes, and detection of any what we call B symptoms or constitutional symptoms. The workup of a patient with CTCL, it will vary depending on the clinical presentation. We often see new patients sent to us with a potential Mycosis Fungoides diagnosis, but it's not very clearly established. So so the diagnosis of CTCL can be tricky. And the same way that CTCL is often underdiagnosed, there are also many patients which are overdiagnosed. So the sensitivity and specificity of histological diagnosis is not 100%. And it's not 100%, again, because those cells are mature, because eczema can look like Mycosis fungoides can look like eczema or psoriasis. So there's always a dilemma there. When we see a new patient, we may have to obtain multiple biopsies to be able to nail down the abnormal finding. We need to do immunohistochemistry and molecular studies on the tissue, looking for defining a clone in the skin and finding the same clone in the blood may be very important. This identity of abnormal clones is very important. So we do a full evaluation of the skin compartment. Obviously, we palpate for lymph nodes. If there is an abnormal signal with the lymph nodes, or there is a serological evidence of potential blood systemic involvement, i.e. high lactose dehydrogenase markers or some cytopenias, or palpable adenopathy or constitutional symptoms, we then order PET CT scans. And if there is if there is an abnormal lymph node identified, the next step will be to obtain lymph node biopsy. Finally, we assess the blood assessment on all of our patients, whether they are stage 1 with very limited disease or are erythrodermic. So all patients with cutaneous T-cell lymphomas will undergo CBC with a synchronous flow cytometry. Why do you do them synchronous? Because flow cytometry provides percentages which need to be translated in absolute number of cells. So our patients, a small percentage, about 2-3% of patients with stage 1A with very limited skin disease may show already an abnormal signal in the blood that will need to be followed. So all of our patients will have CBC, flow cytometry, LDH, and a comprehensive chemical panel of the blood. All our patients will have a partial or complete analysis of lymph nodes, either by palpation or plus minus CT scans and or biopsy in case of an abnormal finding. And all of our patients may have multiple skin biopsies to fully identify the nature of the abnormal T cells. And that's pretty much our staging approach before we decide on a therapeutic area. Once we have detected an abnormal signal in the skin, which could be clinical or pathological, the clinician should evaluate the blood looking for abnormal cells. In the past, we used to do a CBC, a complete blood count, and find out, number one, if the patient presents with what we call lymphocytosis, or an increased number of lymphocytes, which is a red flag that you may be dealing with Sézary syndrome. And when we detected something abnormal in the CBC, we would do a review of the smear. So a smear of the blood and simply counting lymphocytes. How many abnormal cells are there? Sézary cells are morphologically very distinct from benign lymphocytes. Even though they may be small or medium sized, they have what we call hyperconvoluted, very regular nuclear membrane that those cells can be counted. So under the microscope, a histodec would count several hundreds of cells and find out whether this is Sézary syndrome or not. Now, nowadays, the way we detect it is not so much morphologically, but sending the blood that has shown something abnormal to flow cytometry. And flow cytometry will show us whether the T cells express markers that are typically retained in normal T cells, especially CD7 and CD27. Flow cytometry will also let us know if the ratio of T helper, CD4, T suppressor, CD8 cells is within normal limits or abnormal. One of the findings that defines Sézary syndrome is the presence of a CD4, CD8 ratio extremely high, over 10:1. So ideally, we check a panel with multiple markers that define B cells like CD20, T cells, CD3, lymphocytes in general, CD45, and then we look at the subsets of helper, suppressor, NK cells, and then those markers that may define Sézary syndrome, which are CD7 and CD26. Well, PROBE was an initiative from Kirin to educate the clinicians, especially hematologists, on how to properly evaluate the blood for patients who are suspected of having Sézary syndrome. So the problem we face is that flow cytometry is done at many different labs, and often the markers used are not the ones that best define the disease. Often the reports may just provide a percentage of abnormal cells. Often they don't show you whether the targeted CD4 positive, CD3 positive cells are the ones that have deletion of the markers. And if you don't have a flow cytometry report that properly evaluates all T cell subsets and provides you a clear assessment of whether there is an abnormal population or not, they may be very difficult to read. So in my experience, A flow cytometry reports may not provide a clear answer sometimes. Again, as I said earlier, to educate especially hematologists on what to look for, when to order a flow cytometry. Why is it so important? Because we want to make sure the blood compartment is assessed early on. We want to make sure that if there is a leukemic component, the patient should be treated promptly for it.